afternoon, sir. Yeah, sir. Audible, right?
आवाज चालू कर दी।
हाँ कर दी सर, कर दी सर।
हेलो जसवंत, हाउ आर यू?
हेलो सर, गुड आफ्टरनून सर। मैं बढ़िया हूँ सर, आप कैसे हैं?
और कैसा चल रहा है आपका वहाँ पे?
सर इट्स गुड सर, अच्छा चल रहा है सर।
एंजॉयिंग?
हाँ कर दी सर।
जी सर।
जी सर।
आवाज क्यों आ रही है बार बार? कितने पेशेंट आए थे ओपीडी में?
किस हेलो हाँ कर रहा हूँ, कर रहा हूँ।
सर आप देवघर आने वाले थे?
आना है यार।
ओके सर।
थोड़ी
राइट।
गर्मी थोड़ी गर्मी कम हो जाए तो आते हैं।
नहीं नहीं, राइट राइट सर, राइट सर।
क्या हुआ इसमें बोले?
आप देवघर आने वाले थे?
थोड़ी गर्मी कम हो जाए ना तो आते हैं यार।
राइट राइट सर, राइट सर। इसमें अच्छी अच्छी आवाज आ रही है सर, माइक को यूज करने के बाद बेटर है सर।
चलो। आपके यहाँ ऑर्थोपेडिक?
जी सर। राइट सर। इसमें अच्छी अच्छी आवाज आ रही है सर, माइक के
क्या कर रहे हैं?
बेटर है।
बुला के लाओ रवि को।
आपके यहाँ ऑर्थोपेडिक?
यहाँ से तो ये भी ले जाए।
भावुक
योर
सर ने ज्वाइन
फैमिली
किया।
इज स्टिल हियर?
Yes sir, they are still there at Delhi only sir.
योर वाइफ
Yes sir.
वर्किंग एज अ डॉक्टर?
Yes sir.
कौन से डिपार्टमेंट में?
Sir pediatrics sir.
एम्स में ही है?
नहीं sir, she is at Delhi Government Hospital.
दिल्ली गवर्नमेंट?
Yes sir.
शी इज वर्किंग इन अ डिस्पेंसरी और अ हॉस्पिटल?
Sir hospital दादा देव मदर एंड चाइल्ड हॉस्पिटल है सर।
कौन सा?
दादा देव मदर एंड चाइल्ड हॉस्पिटल।
कहाँ पे है ये?
सर ये पालम डाबरी वाला एरिया है, वहां पे है सर। नियर द्वारका सेक्टर 1 सर।
अच्छा अच्छा। जसवंत,
सर।
हम
सर।
लोगों ने 2-3 क्विज करे हैं, ठीक है ना?
यस सर।
तो जितने भी क्विज आप करते हैं उसका हमको ना ईमेल आईडी चाहिए। जैसे आपने जयपुर में किया था,
राइट सर।
उससे पहले भी किया था।
राइट सर।
So what we will do, we will send them our NAMS newsletter plus
राइट सर।
guidelines for becoming member also.
राइट सर।
So that would be helpful to them as well as to National Academy.
राइट सर। राइट सर, डेफिनेटली।
Good afternoon, sir.
सुन रवि, इसको ना तो मोड में नहीं कर सकते।
वेबिनार मोड में, हाँ, फिर वेबिनार मोड में लोग क्वेश्चन नहीं कर
मत
पाते
करो,
और
तुम उसको छोड़ दो।
कनेक्शन की लोगों को प्रॉब्लम आती है कि ये नहीं कर पा रहे, वो नहीं कर पा रहे। तो मैं सबने ये बोला कि मीटिंग नहीं करो, तो फिर मीटिंग करने लगी।
तो क्या प्रॉब्लम है, तो उसको उस प्रॉब्लम को सॉल्व करो।
अभी नहीं आवाज कौन सी? 8 बन गए। हाँ, वो तो क्या है, वो तो इतना वो तो फिर जितने लोग हैं राजधानी में, उनको तो आज देखेंगे, क्योंकि उनको तो हमें पहले नहीं देना पड़ेगा, उनको तो देखेगा ही दिखेगा।
उनको देखना है।
अगली बार वेबिनार में फिर 2 बार करा, मुझे सबको दिक्कत आई कि नहीं वेबिनार में कुछ
क्या
नहीं
दिक्कत है?
होगा।
नहीं, कोई वो हम देखेंगे।
ठीक है, तो अगली मीटिंग वेबिनार में, अगली वेबिनार पे लोग ज्वाइन करने में लोगों को दिक्कत आती है।
क्या दिक्कत है?
ये कि जब ज्वाइन करेंगे कभी तो कभी कभी कैमरा नहीं होता, लोग क्वेश्चन पूछना चाहते हैं तो वो चैट नहीं देखते। ठीक है,
नमस्कार डॉक्टर भावुक,
हेलो सर, गुड आफ्टरनून सर।
दिस योर डे।
सर
गुड आफ्टरनून सर।
नमस्कार सर, नमस्कार जी।
गुड आफ्टरनून भावुक सर।
हेलो, हाय।
हेलो सर।
Ravi, we can start.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Jasper sir, please unmute yourself.
Hello and good afternoon, everyone. We welcome you to the next session of NAMS Navigate Medico CME program. Today, a very important topic in orthopedics and in case of any trauma, that is cervical injuries, will be covered. So first of all, to begin with the program, I would like to invite Professor Umesh Kapil. Sir is Secretary of National Academy of Medical Sciences. I welcome sir to provide the welcome address.
Namaskar and good afternoon. On behalf of National Academy of Medical Sciences, it's my proud privilege to welcome all the participants, this respected speaker, Dr. Bhavuk Garg sir from All India Institute of Medical Sciences, the mentor of this series, Professor Raj Bahadur, who has been mentoring the series on the orthopedic lectures. For last 4 lectures have been undertaken on important thematic areas. The Navigate program was initiated by National Academy of Medical Sciences, essentially for junior residents, senior residents, young faculty members, so that they can update their knowledge. We have tried to include the specialist in the district hospital, at the community health centers, primary health centers also. The aim is that they do not have chance of continuing medical education doing routine practice. We hope that these sessions will be extremely useful. This CME session under the Navigate program, which is being undertaken, the main aim is to update the knowledge of our colleagues by the most eminent faculty members in the country. What we do is that essentially we are also telecasting it through our YouTube. I understand there are over 119 people have joined on the YouTube. All the videos of this particular session, all PowerPoints are being uploaded on NAMS virtual library, that is NAMS website. Any postgraduate, any doctor can go through these lectures, and also PowerPoint, they can download it and utilize it for their own CME activities. With these few words, I hand over mic to Dr. Jaswant. My special welcome again to Raj Bahadur sir, who has been very kind to us. Sir, we are grateful to you for mentoring this, our academic activities. We are really proud of you. And Dr. Bhavuk sir, for helping us out and reaching to a large number of our medical colleagues in our humble endeavor of doing the continued medical education. Thank you very much. Over to you, Dr. Jaswant.
Thank you, sir. So, as sir mentioned, a special welcome and a salute to our chief coordinator for the orthopedic series for his tremendous task in coordinating all these important lectures. Professor Raj Bahadur sir, I would like to introduce sir. Sir is the project director and member secretary of Regional Spinal Injury Center in Mohali. He is former vice chancellor of Baba Faridkot University of Health Sciences in Faridkot, director principal of GMCH Chandigarh. He has special expertise in general orthopedic surgery, orthopedic education, spinal surgery, and joint replacement. Dr. Raj Bahadur has a vast experience in spinal surgery. He has done more than 11,500 spinal surgeries in a span of 19 years at GMCH and PGI located in Chandigarh, and 500 spine surgeries at Regional Spinal Injury Center located in Mohali. He has treated around 330 major spinal injuries in the rural and border areas of Punjab. His professional honors and trainings are numerous, and to count with a few, he has been awarded a prestigious JJ Fellowship Award of IOA, British Council Fellowship at Queen's University of Belfast, Fellowship of IGOF at Westfalen Wilhelms University Hospital of Münster, Germany, a fellowship of ASI of Switzerland at St. James Hospital, University of Leeds at UK. He has been awarded Young Achiever Award by Confederation of Indian Industry to talk with Mr. Tony Blair, Prime Minister of UK. He has also been awarded with fellowship of national and international scientific societies, including Fellow International College of Angiology, Fellow International Medical Sciences Academy, Fellow Association of Osteosynthesis International, Davos, Switzerland, Fellow of Indo-German Orthopedic Foundation, Fellow of National Academy of Medical Sciences, India, and Fellow of Institute of Hospital Engineers. He has more than 200 research papers in his name, numerous chapters in the books, and multiple orations. So with this, I again welcome Professor Raj Bahadur, sir. Sir, over to you for the address, please.
At the outset, I am grateful to the National Academy of Medical Sciences for considering the lectures on orthopedics. For this, I think the initiative has been taken by the President, Professor Serene, and then we have very eminent Secretary, Professor Kapil, as well as we have another Deputy Secretary, Professor A.K. Sood. With this program, we have done a few lectures earlier also, like the total joint replacement, and we, in this series, we have cervical injuries as well as lumbar canal stenosis as far as spine is concerned. Today, we are considering taking a lecture on the cervical spine injuries. For this, I would like to say that this is one of the serious injuries which a patient can encounter. And if you go back to the history of the spinal injury and the spinal cord injuries, it is mentioned on the pyramid of pharaohs. The pyramid of pharaohs, these are the pyramids of the kings of Egypt, on which it was written by some unknown person or a physician that the spinal cord injuries, falling cervical spine or lumbar spine, is an ailment not to be treated. So that was the situation way back, that these injuries are so serious that these are not to be treated, because the diseases they were classified as diseases which can be treated, which are the one which should not be treated and where you can do wait and watch. So cervical injury, as I mentioned now, these are very serious injuries, and these are encountered by both orthopedic surgeons as well as the neurosurgeons. And today we would be talking, and I would request Professor Bhavik, who's a very eminent spinal surgeon of our country and a very young, I would say the young, because I've seen him as a assistant professor at PI where we were together, and then now he's a professor at All India Institute of Medical Sciences. And I will request Dr. Bhavik to deliver his lecture so that it should go into the brains of our postgraduate students so that they should be able to do well in the theory as well as the practical, because these injuries, they are so serious that they, if not taken properly, probably can produce a catastrophe at the beginning itself. With this, I request Dr. Bhavik to take over. Thank you, sir.
Sir, it's my honor and privilege to introduce the speaker for today's session, Professor Bhavik Garg. He is currently professor in the Department of Orthopedics at All India Institute of Medical Sciences, New Delhi. He has a special interest in complex spinal deformities, degenerative spine infections, robotics, and MIS. And also he has a very specific interest in artificial intelligence, which is the need of the time. And also he has been working on biodesign, faculty of faculty of School of International Biodesign. He has also pioneered 3D printing in spine surgery in India, first 3D printing in ortho lab that he has established. And he also worked on enhanced recovery pathway in spine surgery. He also contributed by doing 3D gait analysis lab in orthopedics. He also started orthogenetic lab, and he has significant contribution in several surgical techniques, including FlexiWatch. He has been holding various prestigious positions, including member of SRS Patient Education Committee, chair of SICO2 Spine Committee. He is Young Fellow Association liaison representative to the American College of Surgeons Advisory Council for Orthopedic Surgery. He is also past chair to ASSI COVID Task Force. He is also chair of ASSI Research Committee Associate Editor. and editor of numerous journals. He has a fellowship in joint replacement ASSI, spine traveling fellowship in orthopedics and trauma surgery at Germany, and also also Robert Rowe Fellow, SRS Global Outreach Spine Fellow, and ISA Fellow, IOA Fellow. He has numerous academic awards, including DMA Distinguished Medical Services Award, NASI Reliance 2022 Award, DBT Biotech Product Process Development Award, GAPI US Surgical Excellent Award, and many more to add into his achievements. So, with this, I would like to welcome Professor Bhav Garg sir, and I would also like to thank you, sir, for taking out your time for this important lecture. So, welcome, sir, for the talk, and over to you, sir, please.
Dr. Babak, unmute, please.
Thank you, Professor Raj Bahadur, Professor Jaswant, and Professor Umesh Kapil. And thank you, NMS, for giving me this opportunity. So, are my slides visible?
Yes.
So, I will start with the case scenario, as Dr. Raj Bahadur pointed out, that cervical spine injuries, they are quite common, and the consequences as well as the follow-up and the prognosis can be very bad in some of these injuries. So let me start with this case scenario. It's a real life scenario, which incidentally I managed this case when I was in PGI Chandigarh. So this was a 22-year-old male. He had a history of road traffic accident. There was a history of being ejected from vehicle one day prior, and he was managed in a distant local hospital. And when this patient came to the casualty of the PGI, then he was carrying the notes of paraplegia, inebriated state, abnormal mobility and deformity at the left hip, stable vitals, and the chest tube was in situ. So you can make out this is a very common scenario, which we encounter these patients, like, multi-polytrauma patient with stable, with so many injuries. And these were the X-rays which the patient was carrying with him. There was a chance fracture of the dorsal spine involving the multiple vertebra. There was an anterior-inferior rim of the glenoid fracture. There was also the basic cervical neck of the femur fracture. These were the X-rays. So if we so the message here is that, what should be the next? The message here is that besides the whatever the notes patient is carrying, whatever the patient is having the X-rays, we should always give a secondary examination. That means you have to examine the patient again. Now the patient is awake. Earlier, when the patient was examined at the previous hospital, then the patient was in inebriated state. But now the patient is awake. His vitals are stable. Now he's conscious. Now he's also complaining of numbness and the weakness in the upper limbs. And when we examined the patient, he has deltoid power 2/5, elbow power was 1/5, and he was also having pain in the cervical spine. And besides this, he also complained of tenderness in the capitus at several other places like left elbow, wrist, and the right hand. So we ordered, the investigation for all these areas, and we found that there was multiple phalangeal fractures. There was a radial head fracture. There was a transcaphoid parallel dislocation also. So this is the common scenario, and the secondary survey is very, very important for these polytrauma patients, that you should not miss anything. And when we get the X-ray of the cervical spine done, we also saw that there was a dislocation at the cervical spine at the C4-5 level. So now various questions arise, when we encounter these patients. So various questions arise in our mind that, how should we manage these cases? So I'm not going to detail. We will discuss the SLIC classification later on. So the SLIC classification basically tells us that whether we should operate these patients or we should go for conservative management. So if it is more than 3, then usually it goes in favor of surgical treatment. So 10 score is very high, and obviously it requires surgical treatment. So the other question was like how to proceed now. So should we give steroids or not these patients? Should we go for MRI first? Should we do the urgent reduction first? Should we do if we are planning for urgent reduction, should we do it bedside or should we do it in the operating room? We should do it under GA or we should do it under sedation. If we are not reducing it, then what? So these were the questions that are mine, and these are the user scenario which we will discuss when we will go to the presentation. Anyhow, we reduced this patient closed, and we could get a good alignment. You can see here. And now the question arises: now what? So again, a neurological examination, repeat neurological examination is a must. Then again, because it is a unstable injury, so it requires surgical treatment. And then we can talk about the various investigation like role of MRI, CT scans. Patient is having, the certain areas they are prone to retroviral HIV, this thing. So if you're planning surgical, then what first? Like this was a case of polytrauma. So what, which fracture should we operate first? If we are operating these fractures, which approach we are going to use? What surgery we are going to use? Which side, right or left, which we should operate in these cases? So again, these are the usual questions, which we encounter. So anyway, this case, cervical spine is the most vital injury. So we operated this patient in the supine position first. We kept an open mind that we are going to fix all the fractures, if the patient condition permits. So we planned it in the single day, and then we proceeded sequentially. So we first operated the cervical spine, and the other team fixed the hip joint simultaneously in the supine position itself. So we use the classical Smith-Robinson approach we will discuss. So we go between the sternocleidomastoid and the strap muscles, and then we identify the level. Then we prepare the space in between the bones, the C4 and the C5, and we put a cage. And this is a special cage through which the screws also fixed. So this was the post-operative X-ray which we fixed. And then we fixed the. I told you that we fixed with the DHS, the hip joint. And then we put the patient in the prone, and then we fix its dorsal spine. And the prone position itself, we fix the radial head. We also fix the phalanges, and then we also operated the closely reduced the transcaphoid penile dislocation. This patient, we were not expecting that this patient is going to recover, but these were the X-rays post-op, and we had a very good reduction of all the fractures. And to my surprise, this patient came walking to our OPD. So, but the thing is, I was not expecting it. He didn't have power in the shoulders, the elbow, but his hands, they were moving. So this was a classical case that if you give, the proper treatment to this patient, the outcome can be very, very good in these patients. So with this, I will start my talk. So when we talk about the cervical spine injuries, so basically it involves two areas. The management and the understanding of the anatomy is totally different for both of these things. The first area is the craniovertebral junction. That means the occiput, the C1 and the C2. And then the C2 below, the C3 to C7, as we know that there are 7 cervical vertebrae, they come into the cervical spine. So coming to the CVJ anatomy, I told you that it comprises of occiput, C1 and C2. And this is the most mobile portion of the spine axis. 50% of the flexion, extension, and the rotation movements, they occur at the occipital C1 and the C1, C2 joints. And the stability at this region is not by the bony anatomy, but rather by the ligaments, the tectorial membrane, the odontoid process, which is a projection of the C2 vertebra, and the occiput condyles and the C1 joint articulation is provided. So this area is very mobile, and then hence it is also prone to injuries in many of these, the high-speed road traffic accidents. So coming to the important ligaments around this area. So like this is the tectorial membrane, which we have cut, which is basically an extension of the PLL from the C2 to this occiput, the foramen magnum anterior border. The another important ligament is a cruciate ligament, which has got a transverse portion where I'm pointing my mouse. You can see this is the transverse portion, and then this is a vertical portion. So this is very important because this prevents the backward translation of the odontoid. Then there is an apical ligament which goes from the tip to the foramen magnum. Then there are alar ligaments which are on the lateral side, they from the lateral aspect of the proximal odontoid, they attach to the lateral mass of the C1 and the occipital condyle. Then there are other ligaments like ligamentum flavum, and then the anterior and the posterior atlanto-occipital membrane between the C1 and the occiput. So this is very, very important to understand the anatomy, that here the ligaments, they are very, very important. This is another view to just to show you that the sagittal view to show various ligaments, and this tectorial membrane and the cruciate ligaments, they are very important to prevent the translation of the C2. And this is the axial section. Again, you can see that this transverse ligament is very, very important for the stability of the dents. Now, subaxial cervical spine, they are usually from C3 to C7, and majority of the cervical flexion, they occur at this area. Now, if you see the shape of the vertebra, they are relatively small as compared to the thoracic and the lumbar spine. This is basically because these bones, they have to bear a relatively less load, because they have to just bear the weight of the head and the area, so they are relatively small. And if you look at the discs also, they are also small as compared to the dorsal spine and the lumbar spine. But if you look at the ratio of the disc to the bone, they are actually quite high. And this is basically because there is a movement. The majority of the cervical movements, the disc, they are very important, and hence the disc vertebral ratio is quite high here. So this is because of the excessive movement required in the cervical spine. And normally the cervical spine is lordotic. That means it is curved anteriorly, which is again tells us that majority of the weight transmission occurs through the anterior column, and this is very important to restore the anterior weight bearing column in most of these injuries. Approximately 50% of the rotation occurs from the subaxial spine. Now, subaxial cervical spine injuries, they contribute around 3 to 4% of all trauma patients. That means whatever trauma patients you are having in your casualty or this thing, the 3 to 4% of these patients, they may be having the cervical spine injuries. Now, if we look at the alert patients versus the patients who are inebriated or unconscious because of the head injury or this thing, the ratio is around 3:1. That means that if the patient has got head injury, or if the patient is under influence of alcohol, then the incidence of cervical spine injury is very, very high, and a treating doctor should be very, very cautious about the cervical spine injury in these cases. And 40% of these injuries, they are quite unstable if we talk about the subaxial cervical spine injuries. Now, this is just to show you that the little bit anatomy, how it is different. So if you look at the anatomy of the subaxial cervical spine, so there are projections, lateral projections you can see here. These are the uncinate processes, uncovertebral joint they form from the like this is the uncovertebral joint, and these are medial to the vertebral artery. So these are very important. They prevent the lateral translation of the vertebrae. And the facet joints, they are relatively unstable in cervical spine because they provide movement. But again, if you look at, there are around 30 to 45 degrees of orientation here. In the spinous process of C3 to C5, they are like bifid, and in C7, they are quite prominent, and that's why we call it as a vertebral prominence of this area, and it is a very, very important landmark for your surgical anatomy. Again, the ligaments in the subaxial cervical spine, we have the anterior longitudinal ligament on the anterior surface of the vertebrae, and then we have the posterior longitudinal ligament. The posterior longitudinal ligament is the most crucial ligament in terms of biomechanical stability. So people have done the transection of the posterior ligaments, then they found that until the PLL is broken, the PLL is cut, there is still some stability. But after PLL cut, the stability reduces drastically. Then posteriorly, we have the ligamentum nuchae, supraspinous and the interspinous ligament, ligamentum flavum, and the facet joint capsules like any other part of the spine. Vascular anatomy. So this is important to understand that in cervical spine, what is different? So from the lumbar spine, the thoracic spine is the presence of vertebral artery, which supplies to the brain. It originates from the subclavian, and there are the foramen called the foramen transversaria from C2 to C6, through which these vertebral arteries travel. Again, if you're operating these patients, then you have to be very careful about this thing. And many of the times, if we are planning the surgical procedures, we get the CT angio done to look at the position of the vertebral artery. Spinal cord diameter in the subaxial spine is around 8 to 9 millimeter, and it occupies around 50% of the canal. The neural foramen is basically covered by the pedicle above and the below. posteriorly there are facets, and the disc and the body and the uncinate process are anteriorly. So this is, the area is actually this thing. And if the patient has got a congenital stenosis or congenital problems, then slight injury can cause the significant neural deficit in these patients. Now, what is instability? So concept of instability is very, very important. That we define instability that if the spine is not able to bear the physiological loads, that means the physiological movements that, he's not able to support the head, that means that the patient is a high risk of initial or additional neurological deficit, and it can ultimately lead to deformity or pain also. So this is the instability, and all trauma patients who have got injury to the cervical spine, we have to assess this instability. And we have any doubt of instability, then it is better to fix and stabilize that segment rather than going for conservative treatment. So people are given various scoring systems also. This is just to tell you that how much the important the areas are. But nowadays we use the slick classification, which we will discuss later on, which covers all these points. So there's no need to remember all these things, but this is important that all the components, the anterior elements, the posterior elements, the orientation of the cervical spine, they all determine the stability. So whenever you encounter a patient of a polytrauma or a patient suspected of having cervical spine injury, then a detailed history is very, very important. And if the patient has got age more than 65 years, if the patient has got a very high risk mechanism of injury, like, there's a history of high speed accident, if there's a history of patient being ejected from the vehicle, if there's a history of fall on the neck or the head, then these are high risk injuries, and you should always keep the cervical spine injuries in your mind unless and otherwise ruled out. On physical examination, if the patient is conscious, then you look for the neck pain. 84% of the cervical spine injuries, they have midline neck pain. 20% of these, the clinically significant spinal fractures with negative plain films, they can be detected on CT scans. Always try to look at the step off between the spinous processes. Look for any crepitus anywhere in the neck. Range of motion, if the patient is cooperative, if there is no pain, if there is no neurological deficit, only then you should look for the range of motion. Otherwise, range of motion should not be checked in an acutely injured patients. And detailed neurological examination is a must, which should include the cranial nerves as well as the rectal examination, because they can be the first signs of a ongoing neurological deficit. Now, if the patient has come to you in the casualty, then what imaging should we do? In which patient should we do the X-rays or the imaging? These are very important questions. And we discussed that 3 to 4% of patients, they have cervical spine injuries of all major trauma, and they're very bad things to miss. So lateral X-rays, they can detect 60 to 80% of the fractures. Our CT scan, it can detect 97 to 100% of all the fractures. MRI is very useful for detecting ligamentous injuries, not good as in element fractures, posterior element fractures, but CT scan is a must. So if you have the facility of CT scan, then straight away CT scan, like at AIMS Trauma Center, as a protocol, all major trauma patients, they go for CT scan. And there's no need to get the X-rays done in these patients, because if you have the facility of CT scan, then CT scan is the best modality to rule it out. Now, people have given several criterias that, which patient should go imaging or which patient should not. So if the patient has got no clinical, the symptoms or sign, like no tenderness, no evidence of intoxication, normal alertness, no deficit, no painful distracting injuries, then they can escape the imaging, and the physician can, or the surgeon can, on his own merit, can decide that this patient doesn't require the X-ray. This is the Nexus criteria protocol. However, there is a Canadian C-spine rules also, that they divided into all injuries into 3 categories. If the patient has got high risk factor, like more than 65 years, if the patient has got any dangerous mechanism of injury, that means if there is a fall of more than 3 feet or 5 stairs, if the patient has an axial load, that means the fall on the head. If there is a high speed injury, rollover, ejection, if any of these things is there, then patient should go for imaging. If the patient has got low risk factor, and if there is no the neck pain or the midline pain, then there is not required any if the patient is able to rotate his head, then it doesn't require any imaging. However, if this is not the case, then again we should go for imaging. If the patient is able to rotate its neck or not, then again we should go for imaging. So basically, these were the rules and the Canadian C-spine rules and the nexus criteria. They are useful, but nowadays what we follow this terminology which we call as a clearing the C-spine. And in clearing the C-spine, basically we divide all the patients into 4 categories. The first category is the asymptomatic patient. That means the patient is fully alert and he doesn't have any clinical findings like the nexus criteria. So these patients, they do not require any imaging and they can be cleared off straight away. The second category is temporarily asymptomatic. That means the patient came to you without any symptoms, but now when you are examining him, when you are and this thing, then patient is developing some symptoms like pain or developing paresthesias and this thing, then straight away these patients, they should go for imaging. If you have the facility for CT scan, then straight away these should go for CT scan. If the patient is symptomatic, that means if he has got neurological deficit, if he has got any tenderness, then again they should straight away go for CT scan. The fourth category is the obtunded patients. They have got head injury or they are the under influence and call. So if the patient is these category, then again CT scan is a must in these cases. So you can see that this is a very simple protocol to use in your day-to-day clinical judgment. Now, when we order X-rays, if you are relying on X-rays, if you don't have the facility for CT scan, then these are the usual X-rays, which we get in the emergency room. Now, if you see here, this lateral X-ray is not showing us the C71 area. And this area, again, here at the C1, C2 joint, we are not able to make out, the clear. So one has to be very careful that, the around 15% of injuries, they also involve the lower and the upper cervical spine. And one should be careful, especially if you see here that there is a teardrop fracture also. So there is a very high incidence of, the associated injuries also. And in these cases, again, one should be very careful to get the optimal X-rays. Otherwise, just keep the patient on the collar, the Philadelphia collar, unless you have all the clinical examination in your favor. Now, which X-ray should be ordered? So normally 3 views are advised. The lateral view, which again I told you that this should include the C71, and they should involve the AP X-rays and the open mouth odontoid view like this here. And you should be able to clearly see that this odontoid is actually into the center between the two, the C1, C2 facet joint. Now, flexion extension views, they are very controversial, whether they should be done in the acute setting or not. They should only be done in cooperative alert patient with who is complaining of pain, but all the X-rays and the CT scan, they are negative. Negative study doesn't rule out the injuries. So now the protocol is, if you have the facility of CT scan, get the CT scan done. If the CT scan is negative and the patient is symptomatic, then you should go for MRI. This is the standard protocol. But if you don't have the facility of MRI, then you can look for the flexion extension views. Some people say that if it is painful, CT scan is negative, then give the patient collar, wait for 2 weeks, and then get these flexion extension views to look for the ligamentous injury. So what to look and how to look the lateral X-rays. So this is again, I told you that it should include the C71 joint and the bony anatomy. You should look at there's no, the fracture, gross fracture. Also look at the soft tissue in front of the bones, that there is no abnormal widening of the soft tissues. Do not forget, if you have a fracture in the cervical spine, do not forget the thoracolumbar spine, because there are very high incidence, or 25% incidence of contiguous injuries as well. So this is, I was talking about, that the missed injuries, they are very, very common, that a single spine fracture should, prompt you to look for the second fracture. Now, when we are looking at these X-rays, then we should again occiput to T1. We should look at the presence of lordosis. I told you that the normal curvature of the cervical spine is lordosis. That means it is curved anteriorly. So if there is a kyphosis, then again you should be worried. Vertebral alignment, that all the 3 columns, they are in line. Spinolaminar line of they are called the lines of Swiss-Chook. That means if you draw a line from the posterior border of all the vertebrae and the anterior column of the anterior border of the vertebrae, the spinolaminar line, and then the spinous process line. These are all four lines of Swiss chip. They are, they are parallel to each other. And any break in them, it should again prompt you that there is some cervical injuries. Look at the spinous processes, distance between the spinous processes. If there is an abnormal widening, it should again alert you that there is can be some spinal injury. Soft tissue measurements, again, in pediatric age group, in an adult age group, usually we take 5 millimeter and the 15 millimeter in the upper and in the lower spine as the soft tissue diameter. Look for the alignment of the spinous processes and the AP view, whether they are aligned or not, and C1, C2 articulation on the open mouth odontoid view. This should be your systemic approach whenever you are going to examine the X-rays of a suspected cervical spinal injury patient. CT and MRI, I have discussed. If you have the facility of CT scan is a must. MRI may not be must in many of these cases. However, if you're planning for surgical treatment, then I prefer to get the MRI as well. Look at the disco ligamentous status and the other findings and the status of the cord. Now let us start with the specific injuries, which we encounter in these cases. So starting from the atlanto-occipital dislocation, I told you that the ligamentous anatomy is very, very important. And if there is a disruption of ligaments between the occiput and the cervical spine, then it can lead to the atlanto-occipital dislocation. Incidence is very high in children, relatively higher in children, because they have got a large head. The muscles, they are relatively poorly developed. The occiput C1 articulation is horizontal and shallow. That's why the children, they are highly prone. High velocity accidents, the head-on collisions with pedestrians, they are again very common. Basically, this happens because of the extreme hyperextension of the neck, which leads to sectioning of the tectorial membrane. And again, some other mechanisms are also proposed. Look for the cranial nerve paralysis. Patient is a monoparesis, hemiparesis, quadriparesis, respiratory dysfunction, apnea. Again, this should prompt you that the patient may be having the upper cervical spine injuries. Complete high cervical cord or the sensory deficit. Cruciate paralysis, again, a very classical example. That means the weakness in the upper limbs with sparing of the lower limbs. Again, this should suspect that the patient may be having the upper high cervical spine injuries. This is just to tell you that there are basically three types of the occipitofrontal dislocation. This is the Trenalis classification. In the type 1, basically, there is a dislocation anteriorly. In type 2, there is a vertical this thing. So if there is a vertical this thing, then giving traction in these patients is actually dangerous, because this will further accentuates the spinal cord, the neurological status. And in type 3, there is a posterior dislocation. And there are several, the radiological people have given several radiological, the methods that how to identify these things. Some of these are like the Holy method. If you look at the distance between the basion and the dens, if it is more than 10 millimeter, then again you should suspect cervical spine injuries. There's a Dublin method. That means if there's a posterior mandible and the anterior atlas, if it is more than 13 millimeter, or between the posterior mandible and the dens, if it is more than 20 millimeter, then again there can be occipito cervical dissociation. Ratio between the interspinous distance of the C1, C2 and the C2, C3, again if it is more than 2.5, and then there is a Powers ratio from the basion to the anterior aspect of the posterior arch, and from the anterior arch to the opistheon, that means the posterior border of the foramen magnum. The ratio of more than 1 is abnormal, but again sensitivity can be very less. And these are some other methods like the X-line method. Sensitivity is quite less, so I'm not in favor of that thing. The Harris line is very, very good. So you draw a tangential line along the posterior border of the dens. Then you look at the distance between the anterior border of the foramen magnum. This basilar-atlanto index is more than 12 millimeter or less than 4 millimeter. That means it is going either anteriorly or posteriorly. Or if the basion dens index is more than 12 millimeter, then this has got a very high sensitivity of 100%. Condyle C1 interval is again, if you are looking at the open mouth view or the CT scan, this again is very useful for diagnosing the vertical, the type 2 this thing. And more than 4 millimeter in children and more than 2 millimeter in adults, it is diagnostic. MRI, again, it can show you edema in these cases, and you should be very careful in dealing with these cases. Normally, if we are suspecting the cervical spine injuries, then cervical immobilization should be done even in the pre-hospital setting. And there are various methods like inline method that you can give the sandbags or this thing. You should just make it inline. In pediatric age group, because the head size is quite large, then putting in them on a normal, the spinal board can put the spine into flexion, and this can be problematic because this again can, make the unstable spine dangerous. So in these cases, in pediatric age group, you require special boards. Either they are there is a hole on the head side, so the head remains in level with the rest of the spine, or you elevate the rest of the spine so that the neck is in the neutral position. And in some upper cervical spine injuries, they usually require early intubation. Cervical traction is not at all recommended. Surgical management, usually anterior approach is not preferred. You go for posterior fusion with rigid internal fixation in the occipital cervical fusion. And this is just to show you that how do we do these surgeries, that we make them prone, we expose them. We have to be very careful about the anatomy of the vertebral arteries. And then usually we have these special plates called the occipital keel and screws, which goes into C1 and C2. We also use wires, and we can use these special implants. And we can secure them with the help of through the tensionment wires, and we put a lot of bone graft to achieve the fusions. Transverse ligament can also disrupt because of the extreme hyperextension of the neck. This can lead to C1, C2 dislocation. So the interval between the dens and the anterior arch of the atlas, it can increase. And so increased pre-dens interval on a lateral radiograph, more than 3 millimeter in adults and more than 5 millimeter in children, is you should suspect C1, C2 dislocation. There's a rule of Spence. That means if in an open mouth X-ray, if the C1 lateral mass on C2 is more than 7 millimeter, then we should suspect the C1, C2 dislocation, or we can go for the MRI. So this is just to show you that if you look at this, this is the C1 arch, and this is the dens. If you look at the flexion view, you can see here that the distance between the C1 arch and the dens has increased too much. So this is actually diagnostic of the C1, C2 instability. And this is, I was telling about the rule of Spence, that if normally the C1 lateral mass is in line with the C2 lateral facet, however, if there is a lateral overhang, then this is X ratio, this is Y. So X plus Y should not be more than 7 millimeter in stable spine. And people have given again, if the transverse ligament, Dickman classified them. So if the transverse ligament ruptures through its substance, then these are very difficult to heal, and they usually require the surgical treatment. However, if they break from bone, then there is high chances of healing, and then these cases, they can usually be managed conservatively just by immobilization. So in type 1 injuries, in which there is substance tear, we require surgical treatment in the form of C1 and C2 fusion. However, the type 2 injuries, then 3 to 4 months of immobilization, usually preferred Hello West can be done. And if after 4 months, if flexion extension movements, they show instability, then we can go for the surgical fixation. Another injury in this region is the occipital condyle fractures, and this is again classified into comminuted type, and then there is an extension into the base of the skull, and then there is an avulsion fracture. So these type 1 and type 2, they can be managed conservatively, while if there's an avulsion fracture, they usually require the surgical treatment. So type 3 fractures, I told you that require surgical fixation. Type 3 fractures, they can also be associated with the dislocation. Dislocation in any form is a dangerous injury. This one should remember. Now, coming to C1 fractures, there is a classical term given to them is called the Jefferson fracture, and they usually occur because of the axial loading. This thing. So I encountered a patient of Jefferson fracture, a VIP patient who was traveling in an aeroplane, and then there was a sudden, the jerky movement, turbulence in the sky, and he was not wearing the seat belt, and his head just jumped off to the the roof of the helicopter, and then he had this injury, and we diagnosed it on the basis of the open mouth rheumatoid view. And then we got the CT scan, and we found there was a Jefferson fracture. So again, 3 types basically. So type 1 is either the fracture is confined to only one arch, either the posterior arch or the anterior arch. Type 2 involves both the anterior and the posterior arch. So basically, this type 2, they are the most unstable ones. And the type 3, there is a fracture of the floating lateral mass. So because this is a spinal canal spending lesion, that means this Jefferson fracture is actually increasing the space for the spinal cord. So rarely it is associated with neurological deficit. And type 1 and 3, they are stable injuries. They can be treated with stable rigid cervical immobilization. Usually I prefer the cervical collar, rigid collar, or you can use a 4-post collar in these cases. Type 2 fractures, again, I prefer to go for surgical treatment, and C1-C2 fusion is required if the transverse ligament is disrupted. C2 fracture is again 10 to 20% of the spinal fractures, and the dense fracture is very common, especially in elderly. In 34% of these cases, the additional spinal injury is present. So dense fracture should prompt you to look for the other injuries as well. So this is the classification. In type 1, there is basically an avulsion fracture of the tip of the odontoid. In type 2, there is a base of the odontoid. And in type 3, it is also through the body. I'm not going into the details, but the thing is they have also divided the type 2 into basis of the displacement and the combination. Basically, the type 1 and 3 fractures, they are stable injuries and they can be treated conservatively with collars. Type 2 fractures, they usually require surgical treatment, and usually they can be very well treated just an anterior odontoid screw in almost every case. Still, there are some cases which require the special treatment. Non-surgical management is usually done with the cervical collar or the halo vest. Now, people are arguing because the halo vest immobilization, it has got the several complications. So now people are moving towards the rigid orthosis itself. Many people, they have shown that the collar itself, if wore properly, then it provides sufficient immobilization. However, if you are in doubt whether the patient is not compliant, then it is better to go for surgical treatment rather than this thing. So surgical management is preferred for type 2, I told you, and odontoid screw fixation is a very preferred this thing. Posteriorly, you can use either wiring or you can use several screws of this thing. So these are basically 3 modalities that if you can use this anterior screw from the front, from the base of the odontoid, you fix the odontoid tip like on the lag screw principle. And this method is called the Magral screw fixation, the transarticular fixation. You from C2 through the pars area, so you catch the arch of the C1. Now, sometimes what happens if you look at especially in this X-ray, you see this P. This is called the high vertebral artery. So these cases, if you try the fixing the C2 the magral fixation, then these patients, they are at high risk of injury to the vertebral artery. So in these cases, people prefer the C1 C2 pars screw or the C1 C2 pedicular screws, and this is the C1 C2 posterior fixation. Another variety is the hangman fracture, which is basically the traumatic spondylolisthesis of the C2 spine, and the usual mechanism of hyperextension and the axial loading. Patients present with neck pain. Now again, this is a spinal canal expanding lesion. So the neurological deficits, they are quite rare, because it is actually increasing the space for the spinal cord. So 1/3 again patients will have the additional spinal injuries. So this is the parts of the C2. That means so this is the superior articular process of the C2, and this is the inferior articular process. So the C2 has got special anatomy. So this area is quite large, and if there's a fracture here, that means it separates the superior articular process and the inferior articular process. So this is very special fracture, and this is the classification by Levine and Edward. So the type 1A is there's just a undisplaced fracture. In type 2, there's a displaced fracture. There can be some angulation anteriorly, but the inferior articular process remains there in contact. However, if there is a dislocation of the inferior articular process also, then it is the type 3 injuries. Now, there is another variety called type 2A. So in type 2A is actually not the typical hangman, it is the atypical hangman. What happens, besides this injury, there is also a fracture which is going through the posterior vertebral body. So the posterior vertebral body fractures makes a special thing, and it usually requires the surgical treatment. So type 1 can be managed with surgical treatment. Type 3 and type 2A, they always require surgical treatment. Type 2, this if it is not significantly displaced and it can be reduced conservatively, then it can be managed conservatively with the halo vest or the rigid cervical immobilization. Always get the CT and the MRI. CT angiography is required if you are going to plan surgical treatment. I told you that type 2 requires surgical treatment if there is subluxation is more than 5 millimeter or there's a more than 30 degrees of angulation. This we have discussed. Fraction is usually avoided in these cases because it increases the deformity. Now, coming to the subaxial cervical spine, the mechanism of injury, again, there are either can be a flexion injury, or it can be hyperextension injury, or it can be an axial roll. So if we look at the flexion injuries, now, when we talk about flexion injuries, it is very important to look at the center of rotation. So where is the center of rotation? So if the center of rotation is posterior to the vertebral body, that means this portion is opening up and this portion is compressing. This area is getting compressed. So these are this thing. So in stage 1, so there are various stages have been described. So basically in type 1, there is a mild to moderate compression. In stage 2, there is a severe compression. And in type 3, this anterior-inferior edge of the superior vertebra, this actually bisects the anterior portion and it looks at the teardrop fracture. And this is again the more severe varieties when there is a disruption of the posterior structures also, and then it can lead to, in extreme stages, it can lead to retropertion of the posterior fragment of the canal, and this is very serious injuries. So hyperextension injuries, they are very common, especially in a fused spine. So in ankylosing spondylitis patients, you should always suspect, or the diffuse idiopathic skeletal hyperostosis patient, any injury, any neck pain, you should be thinking of hyperextension injuries unless proven otherwise. Now, distraction flexion injuries are when the center of rotation is in front of the body. So that means that the center of rotation is here. That means that this will lead to the distraction of all these structures, and these are again various varieties, and in extreme stages, these vertebral bodies, they can go bifacetal dislocation. Burst fracture is a type of flexion injury. In this, there is a comminuted body fracture, and there can be, if it is an acute fracture, this by traction, this can be reduced, and the treatment is basically decided by the neurological status and the instability in these patients. Teardrop fracture, it can occur in the flexion injuries as well, as I told you, that if in extreme flexion, this can cause the teardrop fracture. In hyperextension injuries, this is usually because of the avulsion fractures, and this usually happens in the upper cervical spine, and in the lower cervical spine, this happens due to flexion. And they are usually the flexion injuries, they are unstable ones. So this is an example of an extreme this thing. You can see here that there is a teardrop fracture, and because of the disruption of the posterior injury structures, this body has gone into the canal. So these basically this anatomy, this anatomy, if you look at it, this tells us that there is injury to the front structures as well as to the back structures as well, and they usually require front and back surgeries most of the times. Distraction and extension injuries, again, they are quite rare injuries, but again, here the dislocation can occur posteriorly. Lateral mass fractures can also occur. They usually involve the ipsilateral lamina and pedicle. So basically, the lateral mass becomes floating. And people have described various mechanisms, but usually considered to be extension type injuries. And this usually requires two-level fixation, because if there is a lateral mass fracture, then this is making unstable the two segments, and they usually require two-level surgical stabilization. Now, how to classify these fractures? Various classifications have been given. I'm not going to detail. The AO classification is the most commonly used. Type A is the flexion injuries, type B is the distraction injuries, and the type C is the translational injuries. I'm not going to detail. The most useful classification in day-to-day practice is the SLIC score. So this basically divides, look at the three things. The morphology. If there is no abnormality, score is 0. If there's a compression fracture, burst fracture, you give it score of 2. If there's a distraction injury, that means the facets, they are either dislocated or hyperextension injuries, then you give it 3. If there's a rotational translation, then you give it 4 stage. Look at the posterior ligamentous complex. If it is intact, score is 0. If it is indeterminate, that means if there are MRI signal changes only, you give it scoring of 1. If it is disrupted, you give it a scoring of 2. Then look at the neurological status. If it is intact, the score is 0. If there's a nerve root injury, there's 1. If complete cord injury, 2. Now, here it is important to look at that the incomplete cord injury carries a much higher score as compared to complete cord injuries, because you can protect the patient by doing the surgery in these cases. And if the patient says that, he's worsening neurologically, so this is a special modifier and you give it 1 extra points. Now, if the score is less than 3 or less than 3, then these patients, they can be treated conservatively, no questions. If there's a score of 4, then this is doubtful area, that whether you can manage patient conservatively or not. Then you have to look at the various other things, the patient factors also, surgical fitness also, whether this patient can be managed this thing. If it is more than 4, then there is no question of conservative treatment, and these patients, they should be treated surgically. This scoring has been done, underwent many, the trials. There have been various studies. They have shown that this slick scoring is very, very useful in your day-to-day practice to decide whether the patient requires surgical treatment or not. Now, coming to the management principles of subaxial spines, non-operative care, we can use the rigid collars. There are various collars like the Minerva brace, the 4-post collars. I prefer this 4-post collars as compared to the Halo Vest thing, because this is a midway between the cervical collar and the Halo Vest this thing, and this is very easy and relatively comfortable to the patient, so the compliance is much more. Anterior surgery is basically, if we look at the advantages, because if the compression is anterior, then we could go for anterior decompression. So the chances of neurological recovery is higher. It is relatively atraumatic. We go between the muscle planes. We can do it in the supine position. So acute polytrauma patients, again, supine position is beneficial. Disadvantages are that there are a number of motion segments, they are limited, which we can approach. If it is very high, if it is very low, then again, it is very poorly accessible. So this is how we operate poorly the anterior approach. This is supine position. We pull the shoulders down with the help of these special tapes, and we keep a towel under the scapula to make the neck relatively hyperextension, and we do it under image control. We go by Smith-Robinson approach. We can use a transverse approach. We can use a vertical approach. We go between the sternocleidomastoid and the strap muscles. This is relatively atraumatic, avascular plane, and this is how we expose, we prepare the disc spaces, we do the reduction, and then we put the scan. And this is the usual scar, which the patient has. And because it is along the Harris lines, so after 3 months, the scar is usually not visible. Just to show you an example that we have taken out this disc. In this case, we have put this cage and we have used this plate. So this is a plate, and we fix it with the help of the screws. We should be careful about the length of the screws. They should not be too high, otherwise they will also impinge on the nerve roots. Another example of like this is a CT scan. You can see here that there's a complete decompression here, and this is again, you can see it is very difficult to look at whether the bone has fused or not. Nowadays we have the special cages called the peak cages, and in these cases they are the transparent cases. You can see clearly radiolucent cases, so you can see that clearly there is a bone formation between the cages. Burst fractures, they require a special merit because they usually require the corpectomy. That means you take out the whole of this thing, and then you put a bigger graft, or the cage or an iliac crest graft can be used. And supplemental, you can give the posterior fixation also if the patient is osteopenic. Or I told you that look at the anatomy, look at the mechanism of injury. If you suspect that the posterior ligamentous complex is also injured, then you should also go posteriorly as well. Now, this is an example of a burst fracture. In this case, we have done the corpectomy and we have put an iliac crest graft here, and then we have stabilized it with the help of a plate. Another case, we have used the plate and the iliac crest graft. Posterior surgery, the advantage is that it gives the rigid fixation. You can decompress the foramina if there's a nerve root injury. You can correct the deformity. You can go up to occiput and the lower down the thoracic spine. You have various implant choices, like you can use pedicle screws, you can use the lateral mass screws, you can use the laminar screws. So there are various, the areas to put the implants. The disadvantage is that the anterior cord decompression is not good. Patient has to be operated in the prone positioning, which may not be good for a polytrauma patients, and also the blood loss is relatively more in posterior approaches. Lateral mass screws, we usually put the screws in the lateral mass, and there are various techniques, the Magarel technique, Roy Camilli technique. I'm not going to detail, but usually you start in the center of the lateral mass, and then you little bit go outward and superiorly get the purchase in the lateral mass. So what are the treatment guidelines? So when we should, so if there is a burst fracture with spinal cord injury, if there's a disc involvement, if there's a significant compression of the anterior column, if there's a posterior comminution, then you should go by the anterior approach. If there's a posterior approach is used, if there's a suspected ligamentous injury, if there's a lateral mass fracture, if there's an anterior comminution, multi-level fractures, cervicothoracic junction, rigid ankylosed spine, then you require the posterior approach. And in certain injuries, you have to do front and back surgeries as well. Like in this case, the surgery has been done both the front and the back. Now, there's another entity called facet dislocation. So there are basically two types, the unilateral and the bilateral. Unilateral, usually the dislocation is less than 50%. It is around 25%. This is basically stable injury, and they can be reduced, closed, and then you can decide the approach to treat these fractures. Bilateral facet dislocation, if they're acute, you can reduce them, close, but they are quite unstable and they usually require surgical treatment. Unilateral facet dislocation, people can treat them non-operatively, especially in elderly patients. However, the incidence of neck pain is very high later on. So people now prefer them reducing and fixing this thing. And you can either go anteriorly or posteriorly, depending upon the stability. This is an example of an unilateral facet dislocation. We reduce it closed, then we fixed it anteriorly with the help of a cage and screw construct. Bilateral facet dislocation, spinal cord injury is reversible if you reduce them early. If MRI is required, if there is a significant cord deficit, then you should reduce prior to MRI. And this should be done when the patient is awake in the operating theater. And if the patient during reduction complains that there is a paresthesia or neurological status declining, then you should abandon the traction and then you go for MRI. If the close reduction is difficult, if the patient is neurological stable, then perform the MRI prior to the operative treatment. Close reduction and the should be done under the imaging, and definitive treatment requires surgical stimulation. If you are able to reduce it close, then get the MRI, look at the disc injuries, and then go for the fixation. If poor bone quality, consider posterior fixation also. This is a case of bilateral facetal dislocation, and this we could treat it anteriorly with the help of the plate and grafting. Again, ankylosing spondylitis patient, be very careful. If there's a neck pain, treat it as fracture. Obese patients, you should be very careful. Poorly imaging patients, distracting injuries, rotational injuries, you should be very careful. There's another entity called central cord syndrome. This is seen in the elderly patients. Because they have this spondylotic spine, that means there is hypertrophy of the ligamentum flavum. There is disc, the protrusions. So any hyperextension injuries, it can pinch the spinal cord between the hypertrophied structures, and especially if the patient is traveling in a car high speed, there's a sudden break, then these patients, they can develop the central cord syndrome. Now, in central cord syndrome, usually the prognosis is good. Nowadays, people are telling that the central cord syndrome, they should be the earlier we used to say that the conservative treatment is good, but now people are going more and more in favor of the early surgical treatment in central cord syndrome also. How to diagnose central cord syndrome? Remember the mud. The mud is basically that the motor involvement is more than the sensory involvement. Upper limb involvement is more than the lower limb involvement. The distal involvement is more than the proximal involvement. So if these clinical examination, if you find mud, then you should think of central cord syndrome. And surgical options, again, depending upon the site of compression, you can choose the anterior or the posterior approach. Traumatic disc herniation is also a modality. Now, what happens after reduction? Sometimes the disc is seen protruding because there's a the anterior translation. So if the disc is behind, posterior to the posterior border of the distal vertebra, then you should call it as a disc herniation. Otherwise, it is just a finding of the facetal dislocation, and then it should not be called as the herniation. And if the traumatic disc herniation, again, the surgical outcome is very, very good if you treat them very early. To summarize, the successful treatment of the cervical spine injuries, this is based upon your knowledge of anatomy, what is the mechanism of injury, whether you are able to make out the mechanism of injury, compromise of the bony and the soft tissues. You have to stabilize the spine, decompress if there's an neurological deficit, restore the alignment, and ultimately, if you're able to achieve them, in most of the cases, this will lead to a restoring of the function. Thank you.
Thank you, sir, for the very informative session. So, sir, Raj Bahadur, sir.
Thank you,
moderate.
Professor Bhavuk. You have very elaborately described the cervical injury. And I will ask Dr. Jaswant to ask the participant to ask any question if they have. So after that, we'll go ahead like that.
Yes, sir. Three questions that has been posted on YouTube. First one is thank you for this wonderful talk, sir. Which criteria for cervical spine fracture is followed legally in India? CCR or NEX, US or any other criteria?
So in India, there is no fixed guidelines. The Nexus criteria and CCR, they are not for India. But I told you that most of the time, the literature-wise, nowadays people are following this criteria. They're dividing them into 4 categories: asymptomatic patients, temporarily asymptomatic, the symptomatic, and then the obtunded patients. So these 4 categories now they are very easy to use in your day-to-day practice, and the imaging should be based upon these 4 criteria. I follow these 4, this classification, for this thing.
Right, sir. So next question is, sir, what are the absolute indications for surgical management of cervical injuries?
I told you that nowadays there is no role of the subjective decision that this patient, I think that they should be operated or not. The important thing is slick scoring. If this slick scoring is more than 4, there is no question these patients should be operated.
Right, sir. Sir, another question is from a medical officer. Good afternoon, sir. I'm working as medical officer in district hospital. What are the key issues related to airway management in a polytrauma patient with suspecting C spine fracture?
Yes, so this is very, very important. Then, and it is very important to realize that when we talk about the ABC of the primary, the ETLS protocol, the A stands for the airway control with cervical spine control. A is not just the airway, it is the airway with cervical spine control. So the cervical spine immobilization is very, very important. And this should be cleared by the treating surgeon or the physician, not by the pre-paramedic on the site of injury. So if the patient is wearing helmet, if you are not aware that how to remove the helmet properly, there are proper techniques to remove the helmet, then you should not try to remove the helmet, and it should be very carefully removed under the proper thing. If the patient is on the site of injury, then they should be inline immobilization. That means that you have to maintain the cervical spine in neutral position. You can use either the sandbags or you can use the various techniques. People have used even the newspapers, also to strap it to make it into the inline. So inline mobilization of the cervical spine is very, very essential, and no traction should be given, unless you are sure that the traction is going to help you, and it should be done under the neuro monitoring, under in the operation theater, under the imaging control.
Right, sir. Thank you, sir. These 3 questions were posted on YouTube, and now I think, sir, any comments from you,
No,
Professor Raj Bahadur, sir?
Dr. Bhavuk, now we will ask to you some questions which are probably not undertaken by you as far as the cervical injury is concerned, which would be very useful for the students appearing for the national board or for a postgraduate examination. So, how much traction you can give to a patient of a injury initially while shifting the patient after the extrication or transportation if you need to do it?
So you mean while reducing the cervical spine?
No. You have taken the patient, there's an accident, and you have taken the patient, held in the hands, put a cervical collar, and that if you wish to put some traction, how much minimum traction you can put to the patient?
Ideally, as per the ATLS protocol, no traction should be given by the paramedics at the site of injury.
Okay. So if the patient comes to the hospital if you have decided that this patient require a traction, how much traction can be given to a cervical spine?
So normally in my practice, the people have said that authors have said that up to 70% or the 75% of the body weight can be used as the maximum traction. But usually we start with 5 kilograms of the weight, and then we gradually increase by 10% up to the maximal possible. So this should be gradual. This should not be straight away the maximal load possible. Usually we start with 5 kilograms and then we gradually increase it under the proper neuromonitoring, the neurological control, and under the image control.
I remember as a house surgeon, we gave a traction to the patient, and the patient has a respiratory arrest,
Yes.
and that is very important. So as Dr. Bhavuk has said, that it should be like the traction should be started gradually, and the maximum can be 12 kg and with the increment of 5 kg. This is what is given in the books for the postgraduate student. So we start with the 5 kg of traction and gradually increase to maximum of 12 pounds if the patient has to have this traction. Otherwise, as he has said, that it should be according to the weight of the patient. Dr. Babu, would you like to talk something to the postgraduate regarding the whiplash injuries?
Yes. So whiplash injuries, so there I talked about the central cord syndrome. The whiplash can cause the central cord syndrome in elderly patient. And in children, it can cause a special injury called the cybora. Because when there is this thing, the children, their necks, they're quite elastic. And what happens that, the excessive movement can occur. And when you get the X-rays or the CT scan, there's no injury. And when you get the MRI done in these cases, then you can get the severe edema in these cases. So whiplash injuries, they are very common, especially when you're traveling. And then what happens, your body is stabilized, but your head keeps on moving. And then it comes back, and then this can cause the severe cervical spine injuries. So in elderly, they are very prone to cause the central cord syndrome, and in children, they are very prone to cause cybora. So if in children, so again, this you should keep in mind that these cybora basically stands for the spinal cord injury without radiological abnormality. So again, these things should be kept in mind.
So Bhavuk, if a patient of a Shivora, where the alignment is very well and it has come back, but on the MRI, we see there is an edema of the cord. How do you take this patient for treatment?
Sir, first of all, important thing is that these patients, they are usually managed conservatively. Unless there is a ligamentous injury documented, there's no role of surgical treatment. But the important thing is, if you see that there is an edema on the MRI, then these are very prone that this edema can progress superiorly also, and it can involve the respiratory centers also. So these patients should be monitored very carefully, and an ICU backup should be ready for these patients.
Another question which is very commonly asked, that in cases of the fracture odontide, we have discussed about the type 1, type 2 and type like part of the body. Why there is a non-union in fracture odontide? So
this is a very important question, that there is a watershed area. That means the blood supply of this area is very precarious. There is a disruption of the blood supply in that area. So basically the type 2 fractures, they are very prone to non-union if you don't operate. The another thing is the fracture anatomy. So if the line is going from the posterior superior to the anterior inferior, then they are very good candidate for the surgical fixation. But if the line is going from the anterior superior to posterior inferior, then their chance of shear forces, they are very, very high. And these shear forces, they can also contribute to the non. So number one, the blood supply, and the number two is the shear forces. Depending upon the fracture anatomy, they also contribute to the non-union in the odontine fractures.
Dr. Bhav, would you describe for the postgraduate, how do we reduce a close reduction of the cervical injuries? Close reduction, whether there is a unilateral or a bilateral dislocation.
So again, this is
another common question which
yes,
is asked.
So again, as sir pointed out, that in bilateral fascicle dislocation and the unilateral fascicle dislocation, if there's an acute injuries, then close reduction should be done in the operating theater. Number one, it should be done under the image control. Patient should be conscious that you are asking that looking for any neurological deficit or not. So you give the gradual traction, and then unilateral fracture dislocation, you have to give a little bit rotation also. While the bilateral fascicle dislocation, you have to gradually see when the facets, they are in line with the a little bit flexion, and then you gradually give traction, look at the facet joints when the article process, they are just crossing the inferior article process, and when it's just about to cross, then you extend the length. So that's how you reduce.
Another question, and Dr. Babak, if suppose there is a fracture of the lateral mass, the lateral mass which has gone vertically split, how you will manage such fractures? It's a part of the cervical spine, but then it is only isolated fracture of the lateral mass with the separation.
Yes. So again, lateral mass fractures, they are very notorious injuries because they are compromising the stability of two segments. So if the patient is neurologically intact, then you can discuss the patient that, you can observe if it's a bony injury, then this can be managed conservatively also. But if there is a ligamentous injury on the MRI, then these patients, they should be fixed, and 2 levels should be fixed, not the 1 level.
Just one, I think these are important questions which would I ask Dr. Babak in addition to the topic which he has taken so well. And any question from the side of the postgraduates there?
Yes, sir. Another question that has been posted by one of the participant currently, respected sirs, should steroids be given to all the patients of cervical injuries?
So steroids, actually, as per the new guidelines, steroids, they are not indicated. Not indicated. The original NASIS protocol was that if the patient comes to you within 24 hours, then you should give the, the 5.4 milligram per, 30 milligram per kg bolus, and then followed by 5.4 milligram per kg per hour for the 24 hours. If the patient came within 24 to 48 hours, then you give it for 48 hours, the dose. But nowadays, people have shown that the chances of various complications are much more when you give steroids. So steroids as such, literature-wise, it's not indicated. However, many people use it. After 48 hours, there is no role of steroids. In pediatric age group, in penetrating injuries, and gunshot injuries, they are open injuries, they are harmful, and they are contraindicated. Steroids should not be used.
So as far as the postgraduates they are concerned, I must tell them that initially when we were maybe at the earlier stages, we used to fail or pass a candidate on the basis whether the steroids are to be given. Okay. So at this stage, as Dr. Babak has said, that the classifications have been described, the studies have been done, and in that it has been proved that the steroids, they don't play any role. But then in the examination, the postgraduate should be slightly diplomatic in telling that theoretically it was given earlier, but now it is recommended that it should not be given. The dose remains, as he has mentioned, the bolus dose, and then 5.4 milligram per kg. But then smartly he should say that now in these studies, it has been established that it should not be given because of the complication it encounters.
Right, sir. Right, sir. Thank you. Thank you very much, sir, for this very informative discussion. And thank you, Professor Raj Bahadur, sir, for taking a lead in discussing with the important doubts of postgraduate students. So I think with this, I would like to request Professor Ajay Kumar Sood, sir, for the word of thanks.
Thank you very much, Dr. Jaswant.
Sir, okay, you are there, sir.
Dr. Sood has been called by Dr. Sareen, so he could not be here. I would like to thank Dr. Bhavuggar. Really, sir, it was a very, very informative. And I must say that the case studies which you have presented, they were very nice and they were very informative and very learning experience for the students. Because the case studies always goes right into the hard disk of the students, so they always remember what the teacher has told them. That's something very important. My special thanks to Dr. Raj Bahadur, sir, for mentoring this orthopedic series, and it was really nice of him and kind of him to help us, National Academy of Medical Sciences. I would like to thank all the participants who have very attentively attended the session, and my colleagues in the NAMS who organized the audiovisual facilities over here. With these few words, I thank again to all of you with my entire deep heart to all of you. Thank you very much.
That's a couple information like We initially planned 2 lectures, one by Dr. Bhavuk and another was lumbar canal stenosis. Since
Yes,
the speaker was not available physically for this program, so I requested him that when you will come, we will have a real presentation by him. He is Professor Ram Chadha from Bombay. He would be speaking on the lumbar canal stenosis. So the next lecture should be lumbar canal stenosis, and because that is why probably the 2 lectures they are kept, because the first lecture would have taken one hour, and then the second lecture would have taken another hour. But since we have now completed at approximately 1.5 hours, so the session remains closed because Professor Ram Chadha is not physically present. He has given the lecture, but then I think it would be more important if the person who is speaking is physically present.
Yes, it's very right, sir. So with this, we close the session, and thanks again to everyone. And Dr. Bhavuk Saab, thank you very much. Thank you very much.
Thank you.
Ravi, we can close the session.
Sure.
Thank you.
Thank you.